It's my pleasure to welcome everybody again to today's webinar. Cannot thank our speakers enough. We're very excited to have such an amazing panel to speak on optimizing outcomes after upper limb amputation, surgery therapy, and teamwork. And it's my pleasure to introduce today's speakers. So first we have Alta Fried, who is a certified hand therapist and a hand therapy director at the ARMS Clinic. Alta has completed fellowship training at the Philadelphia Hand and Shoulder Center and has completed over 4,000 hours of hand therapy practice. She received her board certification in hand therapy and has presented at numerous international conferences and published multiple articles. And we're also very fortunate to have Alta on our awareness committee as well. Amy Todd is also a certified hand therapist and clinical therapy specialist at the Hanger Clinic. She received her master's in occupational therapy and has been practicing as an occupational therapist for over 10 years. She primarily focused on the specialty services of hand therapy and the prosthetic rehab and has received extensive training with advanced knowledge in amputee rehabilitation and prosthetics training. Dr. Jacques Hacquebord received his MD from the University of Wisconsin, completed a residency at the University of Washington, and a fellowship at the University of California, Irvine. He's a co-director for the Center of Amputation Reconstruction and Chief Division of Hand Surgery at NYU Langone. And then lastly, we have Diane Atkins, who is also an occupational therapist who has been internationally recognized as a therapist in specializing in upper limb amputation with over 40 years of experience. She's a fellow at the International Society of Prosthetics and Orthotics and an honorary member of the American Academy of Orthotics and Prosthetics. And with that, it's my pleasure to turn it over to Diane to get us started today.
Great, thank you. Thank you, Steve. Hello, everyone. Let me get my, whoops, there we go. It's a pleasure to be part of the Global Nerve Foundation webinar today. After being in the field for over 40 years, some of you may be aware that throughout my career, it's been a passion of mine to reinforce the importance of the multidisciplinary team approach when treating upper limb loss amputees. The value of the surgeon, the rehabilitation MD, therapist, prosthetist, and perhaps most important, the patient, working closely together cannot be overstated. I commend Steve and the Global Nerve Foundation for initiating the webinar today, and I'm honored to share this experience with three of the best in this unique space and specialization. I had the privilege and pleasure of working with Dr. Hacquebord and his team at the Center for Amputation Reconstruction at NYU for almost 2 years, and I am thrilled to see the growth of his Center of Excellence there in New York City. Alta and Amy are superb occupational therapists and are two of the most experienced in the United States. I admire them greatly for their desire to share their knowledge and raise awareness as it relates to this unique patient population. And now you're going to hear a little bit from each of them. And Alta, I'm going to turn the stage over to you right now.
Thank you, Diane and Steve, for the intro, and thank you to everybody who's on the call today. Any questions, you can put them in the Q&A box, as Steve had mentioned. So really, the goal of our webinar today was to talk about communication, which is required, I guess, the most important part of the care plan for a patient with such a destructive injury. And communication can happen in different forms at different points in time of the care plan. And communication really is the key to a successful outcome. Communication starts at point 0 in time. So whether it's when the patient comes into the ER, whether a patient is coming for an elective amputation consultation, or whether the patient needs a revision amputation, or if the patient is coming for a prosthetics referral, communication really begins between all the disciplines at that point 0 in time. And communication must take place with all related disciplines in relation to a patient with an upper limb amputation. So we have at our clinic and at Jacques and Omri's clinic at NYU and other similar clinics, have taken several disciplines that we feel are key to a successful outcome for these patients. Surgery, which is a hand surgeon, plastic or orthopedic surgeon; therapy, which can be OT, CHT, a hand therapist, someone that's specifically trained in upper limb prosthetics and rehab; prosthetists, which again should as well be trained in upper limb prosthetics, not someone that sort of knows upper limb prosthetics; and mental health professionals, which are second to last on the list, but probably the most important, as if we don't cross that mental health barrier, it is difficult to get past anything in the rehab or surgical field; and pain management physicians, which are key to managing phantom limb pain, phantom limb syndrome with medication management, virtual reality, or other modalities that they may use. You can advance, Steve. So really, I put this slide here because I feel like this is the most important slide and the most important message for us to get out of today's talk. But think about that we are treating patients with the most destructive injuries, and I think we ought to spend time with them and with our other healthcare providers that are part of the team that are treating them. And if you look in the research, patients with upper limb amputations often suffer from agoraphobia, depression, anxiety, sleep disturbance. And again, we can understand this because these patients are going through a destructive injury that is leaving them with life-changing consequences. There's a lot of physical strain on the family, the patient, the caregiver. The physical strain is pretty immense, whether it's transporting them to different appointments, whether it's making time for those appointments, whether it's giving up a job or coming late to work for the caregiver, for the patient. The physical strain on the family and surrounding people is quite immense. And therefore, we at the Arms Clinic and at the CAR Clinic and other clinics, like I said, around the country, have realized the need for the communication, the multidisciplinary model. Several of us have set up these multidisciplinary models with all these healthcare providers to provide them the care model with all of their needs under one roof. You can advance, Steve. And I will say that the end result for these patients is really the result, the direct result of the communication. And when the patient has communication between all their disciplines, whether it's in the form of formal meetings, Zoom meetings, text messages, there's always the patient at the center and everybody else is around them. And really the whole is greater than the sum of all the parts, but the decisions that happen when there's all the disciplines together, we have found are decisions that we wouldn't have made if the patient was seeing each individual discipline on his or her own. So you can advance, Steve, and I'll just go into a little bit of communication, decisions, pre-surgical, and then a little bit post-surgical. So pre-surgical communications, this can happen, by a trauma if the surgeon knows what's coming in. This can happen by a revision or an elective amputation. So different scenarios when this can happen, and Dr. Hacquebord will go through some of that in a bit. But basically, pre-surgical, we're discussing length. There used to be kind of definitive lengths, where to cut the finger, where to cut the transradial, and that's kind of gone out the window for most of us because we want to do the optimal length for the patient with everything else in mind: prosthetics, weight imbalance, symmetry. If the surgeon's doing a revision, do we expect a lot of swelling after surgery? Can we get them into an IPAP? Can we get them into a shrinker? Can we start therapy? When are we going to start therapy? Our patients will have a therapy appointment set up for them before they even go into surgery, to show them that this is a team, this is kind of like a bubble that we're surrounding them in, and all of us are communicating. Like I said, there's different forms of communication, text messages, which we'll go through some of the communication post-operatively during surgery. But the goal to remember is that the pre-surgical communication and the multidisciplinary communication is really key to the effective outcomes. And our surgeon Dr. Rajul Shah for the Arms Clinic always says, I'm the least important person in the room. I don't know if I'll say that, but definitely not just standalone, but together with all of us. And Steve, I think you can advance here. So I'll just go through very quickly before Dr. Hacquebord goes through his surgery. Elective amputation, a little plug for elective amputation and a little discussion, since I don't think a lot of people like to talk about it, but in our clinic, it has been something that we talk about when all other options have been exhausted. And that means surgically, therapy, and otherwise. The surgeon will bring the case to the table with the amputation level, why they came to this decision. Our mental health providers will come in, do a full psychological evaluation, make sure the patient is ready for this decision, why the patient came to this decision, and make sure if the patient does go through with this decision, they have all the factors and faculties and functions after to deal with the results of the amputation. Our prosthetists are going to come into the process very early and design a hybrid prosthetic for the patient, which the patient will try for about 3 months until the amputation to decide if this is what they want to do. And you'll see that in the next slide. And then the OT will work with the hybrid prosthesis. They'll work with mirror therapy, desensitization, ADL functional independence. And as you can see, all of these factors play a critical role in the pre-surgical planning for this patient and for the surgeon. And we cannot undermine any of these, because without any of these, I think you're missing a critical portion of the decision-making process. Advance. So I'll, Steve, if you can just play that video on the right, but all our pre-surgical discussions happen in person. Again, like I mentioned, the picture in the middle, discussing the level of amputation based on different parts, based on different componentry, how well the patient did with the hybrid prosthesis, as you can see in the video on the right. Are there muscle sites available? Are there muscle sites above the elbow, below elbow, to determine the level of amputation, like I said. And really, the firm care plan is discussed with all the participants, like I said, patient at the center, all the disciplines, and as you can see in the picture on the left, firming up the care plan with all the disciplines present preoperatively with the patient at the center. Advance. And I will give it over to Dr. Hacquebord to go through some surgical, and then we'll go through why the post-surgical communication is so vital to continue the care plan.
So I'm going to focus on just a few things, because of course surgery, this could be a book about surgery of the upper extremity for amputation care. So some of the things that I think are very important to note is that the upper extremity, unlike the lower extremity, the level of amputation is tremendous variability, right? If it's a shoulder level, transhumeral, transradial, or partial hand, it is a world different as compared to lower extremity, where it's above knee, below knee, and some variations off that. But upper extremity is tremendous, and especially if you just look at the partial hand, there's a near infinite number of variations of a partial hand amputation. So the important thing about upper extremity amputations is the tremendous variability. And whenever we do anything in life, but especially surgically, and especially with amputation surgery, we really have to know exactly what we're aiming for. And I know this picture may seem a little cheesy, but I think it's probably the most important slide today that I'm sharing, is always know what you're aiming for. What is your goal? And the surgical goal is very simplified today, is minimize pain through nerve surgery and optimize function. But as we know, function, of course, is comprised of a multitude of factors, and all of these have to be considered, and the whole has to be considered. But to simplify today, we're only going to be talking about the surgical things objectively, not what's best for every patient under every circumstance. But like what Alta had mentioned, is it is of critical importance to identify the aim, and we do this through discussing with the team. This is pre-surgical, and you sit down, like Malta said, and like Alta had said, we I can't stress that enough. Alta discussed it, but you have to have a team. You have to sit down. You have to discuss, and the surgeon's perspective is the same as everyone's perspective. There's no one person that's running the show or who's the captain of the ship who has a larger say. And this brings us back to, okay, getting our aim. Now, specifically for this talk, I'm talking about nerve surgery. And so nerve surgery for pain is relatively straightforward, and then nerve surgery for function is challenging, right? How do we optimize function? Now, some of the principles that I think is very important for us to remember when we're talking about nerve surgery and amputation care is that you hear the phrase oftentimes, giving the nerve somewhere to go and something to do. I'm sure all the surgeons on this call have heard that, and this is oftentimes what is how TMR, target muscle reinnervation, which I'm sure all of you are very familiar with, is described, is giving the nerve somewhere to go and something to do. However, is the somewhere and the something good? Right? In target muscle reinnervation, we all too often send that nerve somewhere bad and don't give it anything good to do. Now, when you look at quality of nerve surgery, we know what is a good nerve surgery and what is a bad nerve surgery. These things are very well described. I'm talking about outside of target muscle reinnervation, regenerative peripheral nerve interface, all that. But what happens oftentimes is those principles don't get carried over when people start doing nerve surgery in amputation care. And that's a really important question, like why not? Those principles stay the same. When you look at brachial plexus surgery, there's a very big difference in the quality of nerves that are used for nerve transfers. We know that, right? We know that intraplexal is better than extraplexal. And when you're looking at extraplexal nerve donors, you know that there's a hierarchy of extraplexal nerve donors. We know that spinal accessory, for example, is superior to phrenic, which is superior to contralateral C7, and intercostals are also, not as good as spinal accessory. So we know that the nerve going to certain places, there's a hierarchy there, and how that nerve gets there, there's a hierarchy in how you do that. Now, like I said, everyone knows what target muscle reinnervation is, presumably. I'm not going to go in detail what it is, but you take the amputated nerve and you plug it into a smaller motor nerve that's going into a named muscle. Now, do you put the nerve there? You put the nerve there? You put the nerve there? Or do you put the nerve there? That's a good question. Well, I argue that you shouldn't put that nerve any of those places because that is a very ugly nerve coaptation. And you would never do a nerve coaptation like this if you had a median nerve or an ulnar nerve, or you picked the nerve and you needed to repair that nerve either with direct coaptation or with nerve graft. We somehow think that we require the best nerve surgery in those situations, but when we get to target muscle reinnervation or amputation care, we somehow can get away with horrible nerve coaptation strategies. So I argue that we should do something like this. We dissect off a fascicle that matches the size of the fascicle, the nerve that we are coapting to. And the other branch of the nerve, we can decide what we want to do with that, either a traction neurectomy, bury that in bone, bury that in muscle, do an RP&I. But I think it's very wrong of us to do poor quality nerve repairs and call it a targeted muscle reinnervation. We need to do good nerve repairs and modify the TMR appropriately and as necessary. Now, the other thing about target muscle reinnervation and just looking at the hand is knowing where to coapt the nerve to which muscle can be difficult. If you look at target muscle reinnervation in the hand, there's a lot of different algorithms of which nerve should go where, and getting it there can be very difficult. But beware. Beware of the risk of downgrading the patient. This is especially true in very short transhumeral amputations, where if you do target muscle reinnervation in a short transhumeral patient that doesn't have a good biceps, doesn't have a triceps for signal, doesn't have a brachialis for signal, now you are potentially downgrading the glenohumeral motion or the scapulothoracic motion because you are impeding the function of those muscles that move the glenohumeral joint or scapulothoracic joint or stabilize it. This is true in short transradials as well, when you don't have great branches to the wrist flexors, wrist extensors, and you're going to downgrade them and lose important signals. And this is true also just in regular transradials. This can happen. I've seen this happen where good signals are impaired, and you do this all in the name of potentially improving their function in the future. And the same is true in partial hand, as I showed in the schematic before. You can easily downgrade the patient, and the targeted muscle reinnervation may just not reach. So regenerative peripheral nerve interface is a newer technique, as many of you are aware, of taking muscle, a muscle graft and wrapping around the nerve. And this has the potential of not downgrading. With targeted muscle reinnervation, you worry about downgrading the function of the patient. Regenerative peripheral nerve interface theoretically doesn't have that result. And also the potential of generating multiple signals for a nerve and not just one signal for a nerve. Those are two major potential advantages of RPNI. Now, the other thing to think about is, and this is coming back to having the nerve go somewhere and do something, and also what I discussed about nerve transfers. Certain nerves are better nerve transfers than others. Same thing is true for certain nerves, like to go more to muscle or they like to go more to skin. They have different functions. And so I think the dermal RPNI is also something that we must always keep in mind, especially in the hand, where a lot of those nerves are sensory. And so do we really want to take those nerves to muscle, or should we really take them to a sensory organ, a pure sensory organ like skin? Another thing that is new and is very exciting, and this is from my colleague Alex Gardetto in North Italy, who Diane knows very well, and Diane has worked with him extensively, is the targeted sensory reinnervation. Now, targeted muscle reinnervation is taking a nerve and putting it to muscle, but targeted sensory reinnervation is taking a nerve and putting it to a cutaneous nerve. The concept is relatively straightforward, and it once again comes back to having a nerve go somewhere and do something that best suits that nerve. And so this is especially effective in the transradial level, where the majority of the nerves at the transradial level are no longer muscle, they're primary sensory. Of course, there still are the intrinsic muscles of the hand that are motor, but the rest of it is primarily sensory. So rather than putting those nerves to muscle, you can put those nerves to the cutaneous branches, like the lateral antebrachial cutaneous, the sensory branch of the radial, the superficial branch of the radial nerve. And what you then have, as Alex has shown in some of his patients, is that patients are able to map out their hand on their transradial amputation, on their residual limb. So this is early. I don't want, in the research, I don't want you to think that this is now the way that we should all be treating patients, but this is a developing surgical technique that holds a lot of promise. And I think it's important to remember that you want to replace like with like. You want to take these nerves and coapt them to something that makes sense for them. So if it's a primarily sensory nerve, maybe it is best for them to go to a cutaneous nerve that is sensory. So after surgery, whatever you do, you discuss it with the team. Very important. You need to tell the prosthetist, you need to tell the occupational therapist like Alta what you did, what nerve went where, what they can expect. Is there any of the muscle that will be downgraded temporarily in hopes or in anticipation that in 3 months, 6 months, 9 months, that muscle will become reinnervated, and by what will it become reinnervated? So it's of critical importance that these decisions are made as a team beforehand, and then after the surgery, what was done is communicated very directly to the team. The prosthetists and the occupational therapists, they need to know, they deserve to know, and it allows them to fit the patient and work with therapy with the patient and much better. So the summary is the multidisciplinary team, as I've mentioned, as Alta has mentioned, cannot be overstated. And it's a true team. It's not a team just in theory. It is a team that sits down and talks. You just decide on the aim for the patient, where you're going with the patient as a team. You focus on the function, not the surgery. What I mean by that is there's a lot of surgeons that we get very excited about techniques. We want to implement techniques. So when TMR, 10 years ago became really first became popular, there were a lot of people that were TMR surgeons. That's terrible, right? A patient isn't coming in looking for TMR. At least they shouldn't be. They should be coming in looking in for, I need help to regain my life and to thrive in life. And a TMR, RPNI, TSR, all these things, osseointegration, they're techniques. And so you have to decide what are the proper techniques for you to accomplish the aim for this patient. Remember the principles of neurosurgery. Just because we're doing amputation surgery doesn't mean that we can all of a sudden forget all the principles of neurosurgery that are well understood, well documented. And that relates to the somewhere to go and something to do. Whenever we do nerve surgery, is that nerve going somewhere good? And are we giving it something good to do, something appropriate for that? So thank you very much from Dr. Ilon and myself at the Center for Amputation and Reconstruction. And we invite you to join us at the Bionic Reconstruction in Charlotte. This is the second one. First one was in 2023. Next one is in 2026 in April. So thank you very much.
So post-surgical communication, and I just wanted to show real quick how it takes in all the disciplines and brings it all together for the best result for our patients. So surgeon is going to come in with what was done, TMR, RPNI, TSR, combination of both, a combination of all, and the surgeon will mark the sites, and that is all obviously, as Dr. Hacquebord discussed, for pain control, but also to achieve independent, separate, and strong signals for prosthetic control to improve the patient's function. Advance. Our OTs, CHTs will come in next. They're going to work on edema control, wound cure, mirror therapy, and their response to that. And we are lucky to have Amy Todd on the call, who's going to discuss some specifics of rehab and the importance of it. We start with early nerve flooding, EMG testing, and strengthening of the signals, whether it's with COAPT or the Glide IBT system. The patient will begin early on testing and separating and strengthening those muscle sites. Advance. Post-surgical, the prosthetist will come in, with a 3D printed scanner. If we decide for an early postoperative prosthetic, the prosthetist will take care of scanning, printing, delivery, edema status with updates from the OT and the surgeon is important. We don't want to make anything too early. That's going to require an adjustment too soon. Surgeon, prosthetist, and therapist will all work together on muscle site selection. As you can see, the middle picture and the bottom left picture, we're targeting specific muscles and trying to get specific intuitive motions for the patient. And then together, we will discuss the definitive option for prosthetics. Advance. Our mental health provider will do an in-hospital check-in for the patient postoperatively, a referral to psychiatry, that was meant to say, if needed for medication management. And once our patients are discharged, they're going to follow up in person, whether it's weekly, every 2 weeks, with our mental health providers. And then they will be set up with a peer mentor, as you can see in the bottom left. 3 of our patients together with all different amputation levels, discussing just, living life with an amputation, and that is all kind of communicated to us by our mental health providers. So advance. So we can see that, Dr. Hacquebord kind of alluded to this, but we're dreaming big, but we really need to know where we're headed, what's our why. We want to make a difference in these patients' lives, but we also want to make a difference in the correct way. And I think as a team, all of us can contribute to that difference that we make in the patient's life. As long as we all communicate together, do this together, we will get successful results and we will truly make a difference. So I will turn it over to Amy Todd to go into some specific rehab related prosthetic care.
Thanks, Alta. Yes, so let's talk about the rehabilitation of somebody who's had an amputation. You know, we've heard from the other areas and the communication, I don't know that we can stress it enough. Even in places where people don't have access and they don't have the ability to get to a team approached clinic, we have the power to create our own teams. So, I think this starts as soon on the therapy side, as soon as we get a patient. Hopefully we've had access to that team ahead of time, but if we haven't, we just start reaching out. And when we evaluate our patients, we're looking to see, you know, who they have seen, who's already in their care team. Do we have members of the care team who need to be added in? Where can we connect people and who can we connect with, and the best way to actually get that team to communicate seamlessly. So as we're going through this, let's just look at this broken down into a couple of different ways. First, let's look at the pre-prosthesis delivery. So this is done, some of this can even start before an amputation happens if we have access to that patient ahead of time. If not, right after the amputation happens. We're going to look at a variety of areas, and we're just going to break it down right now. So next slide, please. So let's start with the ADL side. Can't stress how much participation and independence mean to a patient, not only just to be able to take care of themselves and get into a more natural routine, but also it's a set of autonomy for them. It helps them understand and advocate for themselves more efficiently. And so when we go into this, as far as the OT side of it, we're going to look at one hand techniques, but I really like to think of it as one plus whatever you have. So in the case of somebody who might have a transradial amputation, it would be their sound side plus incorporating that transradial side as well. So you can see two different pictures here. The one at the top, a therapist actually took some low temperature thermoplastic and made a what we would call a prosthesis, one part prosthesis, one part orthosis, just to give anatomic length and to allow bimanual function to start, so that this gentleman was able to use that to support a plate while eating or to support his pants while trying to button them. If you see the lower position picture, then you've got somebody who's bilaterally involved using a universal cuff and an adaptive cutting board that has some spikes on it to help stabilize the vegetables. Next slide. Trying to get somebody into changing their hand dominance. We know, and we must explain to our patients regularly, that the sound side is going to be the dominant side, whether it was or wasn't to begin with. And that prosthesis is going to be the backup side. It's always going to be the supporting role. So handwriting might be something that needs to change, and definitely that hand dominance. So if we ask our patient, you know, when we talk to people, some people are very unilateral in everything that they do every day, and they don't understand that non-dominant side. And other people are very close to ambidextrous. So we just basically talk with our patient and find out, you know, which way they are, and that kind of determines how much we're going to have to work on this dominance change. Handwriting for Heroes is a good old classic book that allows us to just give our patients a home program, even just for functional writing skills, than when you have to fill out forms. Next slide. We've already talked a lot about mental health and peers. So here are just some great resources that are out there. They all have a virtual component to them. I encourage you to look locally into your local hospitals or any local communities to see who else might have a group for people who have upper limb loss or limb difference. Next. When we look into rehabilitation for the strengthening and symmetry of the body, almost immediately you can see the body starts shifting toward the affected side, as the top photo shows. And this is just due to a lack of weight that happens, and the body just auto corrects into it. Another thing that'll happen is that arm is going to lean into internal rotation. So just by nature, that can already start to traction nerves that had already established their length through the entire life, but now being on an internal rotated position may have some tension involved in them. So during this phase, we might add some nerve glides in there. We're going to look at that lower scapular musculature because if you're not using your arm in space above your head and out to the side, then it tends to get lazy and sloppy. And that's also what can make a prosthesis feel very heavy. We want to look at the core, make sure that core stability is there to help out with just balance. People who have a transhumeral amputation are more likely to fall than people who do not. And then when we are looking at exercises for our patients, make sure that we're instructing them on how they can adjust and modify that activity for the side without a hand. So how are they going to hold a weight or a TheraBand? Next. So we've talked a little bit about the prosthesis side of it. We do want to look at biofeedback, neuromuscular reeducation, and as Alta mentioned, flooding of the neural sites in the brain. Just we want to keep them active and keep them engaged after that amputation. One of the things we can do in therapy is use biofeedback. For a prosthetist in the room, it is a myotester, same technology. And just looking to find where those sites are, we can tell if there has been um, any action in those nerves. Are those sites actually growing in? We can also use palpation. So in the lower picture, you can see the prosthetist while he is working with electrodes already on the arm. He's also using palpation just to feel what is active. So um, teaching a patient how to palpate can help engage the muscles that are already there and like activate that phantom limb to be able um, to elicit contractions that we're looking for prosthetic control. We can also do visualization of those movements pertaining to the transferred nerves. So we're keeping that brain site active. And one of the things that's really good to use with eyes open and with eyes closed is both sides simultaneously. So for example, if we're doing wrist flexion, then what we want to do is we want to have both arms resting 90-degree elbows, wrist flexion on both sides. So that includes the phantom. Next slide. So when we're looking at wound care and edema and limb shaping, these I like to lump in because they're just all kind of early on in the process. That top left slide is where we're looking at the wounds. And so we're making sure that the patient can manage them themselves, that they know what precautions are out there for them, how to monitor healing for signs of infection. But also we can start working, just getting that active range of motion going when approved by the physician. If you see the picture on the right side, you have some skin integrity that still has some issues, but for the most part, we're healed. That middle finger is a little squared off still, which is very common after amputation. And so it's really important to get that limb shape to be more conical. It has an aesthetic reason, but also prosthetics do fit a lot better and the hand functions a lot better. And so does the residual limb more proximally if there is a more conical shape to it. So we do need to do some kind of shaping. While we are tackling edema, it's going to put pressure on the edges of that residual limb, and it's going to help make it more conical. The bottom picture is just some Tubi grip that we use in the clinic. We cut it off of a roll, there's some compression to it, and we can double layer it on our patient. But when we're working with this multidisciplinary team, it's something that we talk to our prosthetist about, and they have shrinkers that they can hand out as well. They are definitely more long-term than anything we can give in therapy. But we need to make sure that we're communicating how that patient is doing with regard to their wound healing, with their shrinkers, with any kind of compression that we might be doing. It does merit that we mentioned figure of 8 wrapping here, which is a gold standard in amputee care. There's a caveat to that. It is a gold standard, but it is a gold standard when it is done correctly. If somebody doesn't have proper support at home, then they don't have the ability to figure 8 wrap well. One-handed it's just very difficult. So that might be something we focus on in therapy, but it's also something that we're going to communicate to the team on which method of compression for edema and limb shaping works better. Next. So finally, since we're talking about nerves today, desensitization, pain, and scars. I like to put these all together. Pain is something that is multifactorial. It can come from 1,000 different ways, right? It can just come from the fit of a prosthesis that maybe has changed. It can come from a neuroma that was previously unknown. It can come from adhesions in the skin or hypersensitivity in the whole area. I encourage you when you're talking with your patients to know the history of the injury. And the reason why is a lot of the incidents that we deal with in upper limb are trauma related. So anytime something is crushed, immediately the human pulls their arm back. And this can cause traction on nerves and tissues all the way up to the neck and the spine, just from pulling away. And so we may need to be looking more proximal for the sources of pain or hypersensitivity. So keep that in mind. The ways that we do deal with desensitization is very specialized to each patient. So we need to know what areas are hypersensitive, like physically on the body, but what causes it? Is it vibration? Is it soft touch, like a light sleeve going over the arm? Is it heavy pressure, like when you lean into the end of a bone? Could it be temperature? And so we need to find out what this is, and then we design a sensory diet for that patient. You can see in the top that we have an immersion and some particles. It's one part soothing and one part can be very helpful in desensitization, but it could also be dowels with different textures, different temperatures. A lot of times massage is going to be very helpful, just getting even close to that area. Mirror therapy has longstanding been proven in amputee care. And also we like to look at graded motor imagery. Now, on the picture on the right, on the left, this gentleman, after his amputation, there was a lot of scarring. Even with 20 degrees of wrist flexion, you could see that the skin blanches a lot. And every time his skin would blanch, he would talk about his phantom being more aggressive feeling. And so just working on that skin to loosen it up, to make it a little more pliable could really help him out. So that's where we're going to look at that. Make sure that we're communicating all the sources of pain and what is working and what isn't to our teams. Make sure that they know that, this pain medication is working well for them, or maybe they're using too much. Let them know if there's any discomfort in a socket and just how they're progressing overall. Next slide. Finally, after the prosthesis is delivered, let's just do a quick overview of what we're going to look at in the training phases for this. So basic training is just right after they get the prosthesis. How do they put it on? How do they take it off? How do they clean it? How do they charge it? This is something you partner with your prosthetist on, making sure that you have all the information you need and that it's reinforced with the patient. We want basic control of all the functions of that prosthesis, and we want to incorporate that prosthesis into a lot of simple bimanual ADLs. So even just passing things back and forth to hold and stabilize. When we start to expand our horizons with that prosthesis, we wind up in more of an intermediate training. So we're progressing that ADL complexity. We're focusing on bimanual tasks still. We progress control of the prosthesis, and we're including on how hard or how soft we're gripping something, or even if we're just doing partial arc moments. And these would be considered a proportional control. And pre-positioning, making sure that the hook or the hand is in the right position for grasping an item so that we make sure that our body mechanics are proper and that we are minimizing those compensatory movements. And then as we have gotten more skill there, we go into that advanced prosthetic training. We're still focusing on the bimanual ADLs, but instead of looking at little tasks, like for example, self-feeding, we're now looking at the entire meal process. How did you cook the food? How did you get it to the plate? How did you get your plate to the table? How are you eating your food? How do you clean up? But we want to divide attention too. We're eating dinner, for example. We still want to talk to people or watch TV or have a conversation. So increasing our speed, increasing the ability to handle multiple tasks at once, really focusing on safety. We also might start exploring work assessments and driving as well. So keeping all of this information, like how somebody's progressing through their protocols, how are they doing with the different types of components? Do things need to be adjusted? Do we see any mental health issues where somebody might need to become they get more frustrated, and sometimes we need a little more mental health integration, if you will. And that is it for my section.
Excellent. Thank you to the speakers. Diane, I will turn it over to you for questions.
Yeah, Steve, did you see any come in? I have a couple of my own.
No, I don't see any Q&A. I actually had one as well, if I could jump in with.
Sure, go for it.
Okay. So everybody, I think on the webinar today, sorry, let me stop screen share. We just one more shout out to the BRECon conference. We'll send information about this with our follow-up as well. It's a wonderful meeting. I was fortunate to attend the 2024, and the organizers do an amazing job with that. But first, like just to kind of get the questions going, I think everybody on the webinar today works at a larger institution that might have these resources, that you have like multiple teams available. Do you have any thoughts or any experience in working with folks that might be, more rural, smaller institutes that don't have the resources on site, and any recommendations for how they could, still build these teams or put this kind of effort together?
In my role with Hanger, I am working primarily with those groups of people. Not everybody has access to the teams that are around, and then even if they have those team accesses, then I will let the other two talk about how they manage when somebody comes in and then goes back to that rural section. But I really do try to bridge that gap, making sure that the therapists have the training that they're looking for individually, but helping them bridge the gap on okay, this is your prosthetist. Let's talk about the best way to get in contact with them. Sometimes I have to play intermediary, but letting them know, this is how you can find your mental health practitioners. This is where you can get peer support, etc. And just really hooking people up. And sometimes it's a matter of staying kind of on top of that little cycle right there to keep it flowing.
Yeah, I'd also like to add, I guess it's my own bias, but I feel that treating the upper limb amputee is really such a complex job, and to do it well really does require a center of excellence. So it's my strong suggestion, actually, for almost any level of limb loss, that the patient and their family seek out where those center of excellence locations are and work very closely with them from the very beginning, surgery especially. rehab medicine, prosthetics, and occupational therapy, because then you can really optimize the outcome, which is obviously what we're all about. Amy, as she mentioned, with her colleague Kelly from Hanger and Alta, and I, in our own unique roles right now, work very frequently with the rural therapists in mentoring and training them after the fact, after the patient has left. And I can't encourage that enough. And thank goodness there are several of us that are doing it, because unfortunately it's simply not taught in the occupational therapy schools today. So, but we do our best, and hopefully through opportunities like this that Steve has offered, we can share the word a little bit better. So, yeah, I don't know. Alta, did you want to add anything to that?
I think you guys both, hit the main points. A center of excellence is ideal. If not, we are so happy to communicate with other therapists. I was just at ASHT, and the question came up a lot with several of our presentations, even in pediatric non-amputee population, of just, we're an adult therapist, we get a peds flexor tendon. Most therapists are so happy to share their knowledge, so happy to do a Zoom therapy session together with you, help you out, find local surgeons, or, ask our surgeons to find somebody local to where the patient is, and help with the follow through and help with the follow up. I think if they come to a center of excellence, it's a strong foundation for us, and for the patient. But I mean, I myself, and I can speak for Amy, Diane, and Carr, and Arms, we're all so happy to help out and facilitate.
Right.
It looks like there was a couple questions in the box, Diane.
Oh, I did not see any. Oh, there we go. Who is the primary contact for establishing an integrated care model? Is it the surgeon, hand therapist, prosthetist? I came from, it's Mike is asking the question. I came from the background of being the coordinator for the Center of Excellence where I worked. So I was kind of running point for the majority of questions that came up. And I find the role of a coordinator really being helpful in that role. Let me see, how do you all navigate challenges with insurance reimbursement, therapy and surgical intervention? Here we are with 2 minutes left, and it's a very, very complex topic. It's all about education, which is the key to everything that we're discussing today. So as I say, that's a whole nother topic. It is one, actually, we are going to be discussing at BreCon, because it's very, very relevant today, because these techniques and procedures and prostheses are not inexpensive. They are very expensive, which again reinforces the importance of centers of excellence for one to get their care and the expert advice and training that is necessary.
If I may just say something about the insurance quickly, the onus is on us to produce good research on this topic, right? I don't want to make the insurance companies as being these big evil entities. I don't think life is that simple as black and white. But we have to give them good data on why. And so the onus is on us to do that. So I think that's one thing. That's a long-term results will bear fruit for that, but it's something that we have to do.
Yeah, Jacques, thanks so much for bringing that up. I can't reinforce that enough. There's just not enough awareness out there, unfortunately, from the decision makers at the insurance level, but we have to keep knocking on those doors. And a few of them are opening, thankfully.
Yeah, I think even just from when I came into this space and working with yourself, Diane, and everybody at the Carr Clinic, it has, several doors have opened. Someone asked the question specifically with Medicaid. Medicaid is definitely tough, but there are people to talk to. We just got a patient, simple myoelectric hand, and we will document with Medicaid, and we will document the benefits of the simple myoelectric hand, but also the difficulties that the patient is having and how she can do so much better with something more complex. Communication, documentation, having yourself and the surgeon be in communication on those letters, on those peer-to-peers is very important, because we've seen, caseworkers from Medicaid turn around and say, oh, that's so interesting. I never knew that about a partial hand. I never knew that this is what the surgery entails. So the more we communicate, the more we're a multidisciplinary team. I think a lot of it is on us to open those doors, use those clinical consultants for whatever company or device you're trying to get approved, and just, work on it. Don't just kind of give it up.
Thank you. Steve, I guess we're handing it over to you because I see we're at the top of the hour.
We are. Do we maybe just have 30 seconds on pre and post-op functional outcome measures?
Good question.
Just really quick. I know we're at 3 o'clock.
So the Ambula is one, the Opus is another one, and then our clinic has been working with Hanger for upper limb specific sort of report cards, so specific tasks that patients can perform when they get the prosthetic, and then at different intervals in time after receipt of the prosthetic. It's a difficult, I don't think it's a difficult question. I think it's a very very normal question to ask.
Yeah,
and you don't have
I
the
think
best answer.
Alta and Amy and I would be available, Steve, for anyone who may want to follow up with any
Perfect.
questions regarding any of these topics after the fact. We are more than happy to
Excellent.
talk
Thank
to
you.
anyone.
Well, thank you, first of all, to all the speakers. Thank you to everyone who attended today. We will send follow-up. We'll also have the recording on YouTube. We'll send a link for that and some follow-up information as well, including some information for BreCon. Again, thank you to our speakers who take time out of their very busy day to not only put together this webinar, but to be here today and answer questions. So thank you, everyone, and we look forward to seeing you at the next webinar. Thanks.
Thank you.